the case, the mental health coding case, since that's one of the chapters we're doing. I just pulled up that one. So again, like I said in the video last night, I recommend that you read the discharge summary first. It's an overview of what happened to the patient while they were in the hospital. Then you want to go to the other dictated reports next. So the history and physical, if there was an op report, if there were consultations, you would read those next. Progress notes from the physician you would want to look at. Now all the ancillary information you don't have to look at. We can't code off those. You know, if a nurse wrote something, we can't code off what the nurse said anyway. So going through those documents can just be a waste of time. Lab and x-rays, you would want to go to those to verify something if you had a question. Like, for example, maybe you're coding a fracture, and the physician told you, you know, a radial fracture, but didn't tell you which part of the radius was fractured. If you have that x-ray, you can go there to get that information, because the radiologist might say, you know, radial head or distal end or whatever it might be. You can get modifying information from those ancillary reports. However, you cannot capture a diagnosis from one of those that the physician didn't document. Same with nursing. Many times, especially when we're coding trauma accounts and the patient was, say, in some kind of accident, the physician might say that the patient was in, say, a one-car rollover, but we don't know if the patient was the driver or the passenger. The physician didn't tell us, but in the nursing documentation, the nurse usually captures a little bit more and might say, you know, patient was the driver in a one-car rollover, lost control of the car, whatever it might be. So we can, again, get the modifying information from those ancillary reports, but we can't get a diagnosis. The physician has to document the diagnosis. And then if their diagnosis wasn't as clear as it could be, then you can look at those other reports to capture that information, if that makes sense. So that's the order I go through. You guys can, of course, do whatever works best for you. So, like I said in the video, make sure to put the admit date and the discharge date current, 2018. Because if you use 2008, you're going to get ICD-9 codes. 3M is very smart in the fact that whatever the discharge day is, it uses the code set from that day. So codes are updated every October, right? So anything, even if we put October of this year, it's going to be different codes than today, because now we're in 2019 codes in ICD-10. So it's important to use a current date just to make sure that you get the current code sets and not the ICD-9 codes. So our patient is a 14-year-old who lives at home with her mother. She just completed 9th grade. She was referred for admission after the police were called to her home with an argument with her mother. She had left the home, and when upset, she had previously come all the way to somewhere. She had been talking about suicide more recently. This was within the context of a long-standing history of depression. She reports having had depression for as long as she could remember. Her grades this year have been poor, not quite F like she reported upon admission, but some Fs, also otherwise a scattering of grades. She reported her sleep as restless. She also had, in 7th grade reporting, taking a few pills. She's not had any antidepressant trials. A week prior to admission, she went somewhere with thoughts of suicide, then was referred to a program. So the hospital course is an overview of what was done to her while she was here. So she was admitted to the unit. A decision was made to do a trial of Zoloft. She also requested help with antidepressant medication. We discussed integration of trial, if effective, at 1 month to continue for 7 to 9 months after that is a general guideline. We discussed the 4% versus 2% risk of increase in thoughts of suicide. Of note, the first day or so, she really did not want to participate in groups. She was withdrawn. She said she needed some time alone. She had also been admitted late at night. She started working on CBT. The staff was very impressed with her effort, the time put into this. She also reported her mood was feeling better. She thought that the medication was beginning to show some benefit also. She also wondered about getting help with her sleep. I discussed this with the mother upon discharge. We decided that if she still had problems at home, we would make a change by perhaps adding trazodone. However, we wanted to make some lifestyle changes first with routines. A family session was held. In the family session, it was discussed, and the patient herself spoke up for the mother scheduling time with her. This was very effective, and the mother listened to her. She also discussed missing mother's previous significant other who had been a big influence in her life. However, we did not get a chance to get into this in detail. Upon discharge, I re-interviewed mother, and we thought that there were not significant symptoms for ADHD and attentive type, as had been previously diagnosed to warrant still persistence of the diagnosis. We discussed how this can be a comorbid with major depression, how having ADHD can be a risk factor for a decline in function that can promote depression, but also the interaction with depression itself affecting concentration. One option we gave her was to consider monotherapy with the Zoloft. However, based on her history of difficulty concentrating in class and with fidgeting, losing assignments even after mother had helped her to complete them, disorganized her room, and school lockers a mess, distracted by sounds, rushing through and making careless mistakes, and putting off significantly that we should proceed with treatment. She had only had Concerta when she was younger. We discussed Adderall XR as the next reasonable option. We wondered if the amphetamine-type stimulant may not help her more than a methylphenidate-based one-on-one on the various delivery systems could be used. Otherwise, there are no major concerns. She's seen by the pediatrician, and then he goes over her labs, no concerns. Mental status, she appears her stated age, casually dressed, well-groomed. She has increased psychomotor activity compared to admission, also restless, fidgety, no tics or tremors. Her speech is regular in rate, not pressure, normal in articulation. Her mood is no longer depressed. Her affect appears bright, stable. She appears more impulsive. Her thoughts are coherent, goal-directed, and organized. No loosening of association or flight of ideas, no paranoia, delusion, or hallucinations. She's alert and oriented ×3. Her memory, recent and remote, are intact. She has good attention and concentration. Her intelligence is normal. Language is normal and comprehensive, and fluency. Her insight and judgment are intact. She denies thoughts of suicide and can guarantee her safety. So the diagnoses that the physician mentions here are dysthymia, and then the attention deficit hyperactivity disorder, primarily inattentive type. Axis 2, there's none noted. Axis 3, asthma, lactose intolerance, mild leukopenia, and she's asymptomatic. Axis 4, school problems with primary support group, and then Axis 4 is global assessment of functioning, score equal to 50. And I just wanted to explain what these axes are. So in coding, there's also a manual called the DSM-5. Now is the version it's in. But the DSM is the mental health manual that has the ICD-10 CM code, so just like we have in our manual, but it also has other information for the mental health clinicians in there. And the diagnoses are broken down by axes. So that's what the physician is referring to here when the diagnoses are listed out by axes. They're just a category inside the DSM-4. It doesn't change how we code them. We would code based on, the dysthymia, attention deficit, hyperactivity disorder, etc. Our coding guidelines are still the same. That's just the format that the DSM-4 uses, DSM-5 now. Discharge medications, those are important, right? We need to know what we're treating, so they have her on the albuterol, the Adderall, and the Zoloft. The follow-up is to a counseling center where she will be in group therapy, day treatment, and we also recommend that the family component's there. Likewise, she will have a child psychiatric follow-up through that office. So the H&P, the reason for admission is where we should start. So she's She's referred for admission after the police were called to the home with an argument with her mother. She had left the home, and before, when upset, she had come all the way from wherever she was, here by the hospital, as a brief episode of running away. Mother was concerned that she may do the same. However, more recently, she'd been talking about suicide. This is within the context of a long-standing history of depression. She reports having felt depressed for as long as she can remember. The symptoms have seeped in and built up more recently. She sleeps excessively, has low energy, poor concentration, and she has had all F's in school last year. She will come home from school and go to sleep. She sleeps all of the time, often in the summer, up during the night, but asleep all during the day. She reports her sleep is restless. Her appetite has been unchanged. She has lack of interest, apathy, motivation, cheerfulness. She gets down on herself, for example. She does not think that she's beautiful. She has reported in the last 2 months, especially having strong thoughts of suicide. She said in the 7th grade she's taken a few pills, but did not get all that sick and did not tell anyone, but the thoughts of suicide were there. Also around that time, she had made some superficial cuts, but she cannot say whether or not it was for suicide. She said, "I was just mad." She's not had any antidepressant trials. A week ago, she went to the emergency department with thoughts of suicide, and they discharged her by referring her to a program. She went to that program for 3 days. She said it's going okay. She's supposed to go to summer school. She does report she's feeling overwhelmed, especially even with the bare minimal expectations for chores at home. She states she wonders why they did not start medication for depression a week ago when she was seen in the emergency room, and is wondering if medication might help her. Otherwise, she has no hallucinations, no drug, no alcohol use. She's not been sexually active, no history of physical or sexual abuse. She has ADHD, which was considered assessed and reassessed in 1st and 2nd grade, but in 4th grade, they thought there were sufficient symptoms for the inattentive type. I did ask for the ADHD inattentive symptoms, but there has been some symptoms like poor concentration, distractibility, but otherwise, the full panel of symptoms, the history was difficult to elicit. She had a trial of Concerta, which led to being like a zombie, and weight loss. She was started on a low dose and then increased. She also has poor appetite with this. The dose was increased to 36 every morning. She reports life stresses, her mother's dating men, becoming attached to them, and then they break up. She does not go into detail. There was a relationship of 3 years with a boyfriend who was good to her, but it ended about a year ago. Mother was hoping to keep some relationship with him for the sake of the daughter, though the mother herself no longer wanted to be in a relationship with that man. She admits that this had been giving her a sense of loss, that she was attached to him. Her biological father has not been involved in her life, nor does she expect him to have those skills. So the past psychiatric history, no previous hospitalizations. She was on the psychotropic medication for ADHD inattentive type. Past medical history, there were no problems during her pregnancy. So the mom's pregnancy with her, right? She was born 3 weeks early. She was the first child. She had colic reflex and had a special formula, and then lactose intolerance. She had frequent otitis media, but no hearing loss, no seizures, no head trauma. She had dysmenorrhea on oral contraceptives for about 2 months, then discontinued and symptoms did not return. She has had mild asthma, so she's on medications, the albuterol, which is for the asthma. No allergies, family history. The biological father has alcoholism, severe. Also, he had a nervous breakdown a month ago. The mother has major depression, who is on Zoloft. She had attempted suicide in 1997. Maternal great uncle had committed suicide by carbon monoxide in the garage. Maternal aunt also with depression, otherwise no family history of bipolar. So social, it states that she has friends who are a little concerned about her. She also plays basketball and is a good basketball player. Otherwise, she admits the mother's breakup with the boyfriend a year ago and reports that she gets all F's in school and is supposed to go to summer school. So review of systems. periodic headaches, stomach complaints, shooting eyes, being sexually active. The mental status, this is exactly what it said before, so I won't go over that again. Same diagnoses on the axis that we saw before, and the plan was to try the Zoloft. So consult, so this is when a specialist has come in. So this is probably a pediatrician coming in for a pediatric health evaluation, where our primary physician is probably a psychiatrist. So this patient is a 14-year-old female who's been admitted to inpatient psychiatry because of depression with suicidal thoughts. She was originally seen at some hospital and transferred here for further care. She apparently denies thoughts to hurt herself. There are stressors at home that have provoked her depression. The patient is quite guarded and does not divulge much information. She has asthma, attention deficit, hyperactivity disorder. She had some fractures in the past. Social history, again, just lives at home. She's on an IEP and is in special education. Review of systems. We don't have to go over the review of systems in great detail because that would be the E&M portion of the code, which we don't do in the inpatient setting. You want to skim and see if there's anything that stands out. Family history, same as above. We went over that. Then the physical exam, again, you would just scan to see if there's anything that sticks out, but all the documentation that we're reading should reflect everything that they see in that information as well as the laboratory. So the impression is that 14-year-old with major depression, suicidal ideations, the patient does not currently endorse suicidality, and then mild leukopenia. And the physician says, I do not think we need to investigate this further, which that's important to know. So we're not going to code something that doesn't warrant treatment, workup, or complicate care. So even though the leukopenia is listed as a diagnosis here, it's not something significant. They're not treating it. They're not even going to work it up. So that we wouldn't code where the major depression and the suicidal ideation are, right? We're talking about those constantly. So those are going to be coded. So the pediatrician says, I have no recommendations other than to check a urine pregnancy test, a urine toxicology, and a urine drug screen. So now the progress notes. These are all the nursing ones. You can see the author says it's a nurse. So again, you could scan over those, but don't spend a lot of time because we're not coding off those. So I'm not going to spend time going over those. Okay, so now go back to the discharge summary and just rescan the discharge summary to see what you need to code. So if we come to our discharge diagnoses, right, we're going to code the dysthymia, and then our patient had the ADHD. One thing that's not noted here is the depression. So we also want to code the major depression, and then the suicidal ideations aren't noted here, but they're noted in the content of the report as well as the pediatrician's consult. We're going to code the asthma, and then we also want to code the family history of the abuse. That's important. And then the patient's personal history of the stress reactions that she's had, like cutting herself and running away, those things. So I'm going to bring up 3M. Okay, so hopefully you guys can all see 3M now. So remember that you want to put the current date, so 9th grade, I think she's probably 14. I can't remember what the documentation said. So I'm going to put 14 into these dates and make sure that the product finder, you keep the DRG finder. We're going to hit continue. So the patient went home. So our first diagnosis is going to be the dysemic order. And like I said last night, if you have the same admitting and discharge, or principle, which is the discharge, you can put that in twice. So admitting diagnosis is really just a placeholder in 3M. It doesn't calculate our reimbursement, our MS-DRG. So I'm just going to put the same code for our principle. So I'm going to hit add diagnosis, and it's F341. So if you know the code, if you look up the code in your coding book first, you can just come to 3M and enter the code like I just did right there and hit OK, and I'll bring up the code in the description. So the next code that we're going to do is that depression. I'm hitting add diagnosis, but my screen isn't doing anything. So hopefully there's just a lag in time here. There we go. So depression, so I'm going to pick 5. And it was a mental. And our patient's documentation said it was a major. And it's recurrent, so I'm going to pick 8. She didn't really have any psychotic features. So I'm going to pick 6, unspecified. But that didn't say severe. So I'm going to back up. So if you hit the comma on your keyboard, you can back up. So if I pick other specified, maybe I can get severe. Nope. Oh, so I have to pick current episode. If you just put your mouse over the keyboard, it'll tell you like what's in each circle. So our patient's documentation did say severe, so I'm going to pick 3, and then right here 3 without psychotic symptoms. And then no psychotic symptoms, so I'm going to pick 2. Okay, now I'm going to add the next diagnosis, which were those suicidal ideations. So I'm going to pick ideation, which is 3. And she didn't actually attempt it. She was just thinking it. So we're going to hit 2. And then do not wish to code. So there's our suicidal ideations. Now let's do the ADHD. So we're going to pick 1. And it did say it was the inattentive type. But we want the hyperactive. Oh, there it is, hyperactive. So I just hit the wrong. Okay. That's the one we want, the hyperactive type. And now the asthma. And we don't know what kind of asthma. It didn't say if it was allergic or exercise, hay fever, so we're going to pick unspecified, the D. And there's not any chronic lung problems. There weren't any exposures, no procedures. And then we want to code the family history of the alcohol abuse and dependence. going to do history, and then it's important here, personal is if the patient currently has it, family is if the patient's family has it. So we're going to pick family, and then we're going to do the alcohol abuse, and there weren't any other conditions listed, so we're going to pick no more. And then we want to do the patient's history of the stress reactions. So again, we're going to do history and then personal. And then I'm going to try to spell stress didn't come up. So it's under combat and operational stress reactions. So that's what we're going to pick, the 1. And there wasn't a follow-up exam, so we're going to pick no. No other personal histories that we need to code right now. So we're going to pick no. Okay. And that's all I jotted down when we went through the documentation. Do you guys, was there anything you guys noticed that I didn't pick up, that I didn't code? Or do you guys have any questions about this case?